Great. With that, we'll move to our keynote address today, which is, we're really privileged to have Dr. Peter Emby join us. Dr. Emby is a professor and chair of the Department of Biomedical Informatics and professor of medicine, as well as a senior vice president for research and innovation at Vanderbilt University Medical Center here in Nashville. You know, he is a true innovator and thinks a lot about artificial intelligence and how we integrate them into our health systems. So we are so privileged today to have Dr. Emby join us. Welcome up stage.
Thank you very much, Dr. Zhang. Thank you all for having me today. It's a privilege to be here with you, and I want to thank my friend and colleague, Kim Rathmel, as well, for pointing me in this direction and suggesting me for this opportunity to speak with you about something I think a bit different than what you've been hearing so far this morning. I was able to come a little bit earlier and hear some of the early conversations, and as a rheumatologist, it reminds me of a lot of the conversations we have at our American College of Rheumatology meetings. Typically not the kind of thing that you're about to hear from me, but hopefully this will be complementary to what you already know, and we'll be able to engender some good discussion for the Q&A about AI and where that's going, and also just more broadly informatics in the health system. Really moving to hear from Wayne, and thank you for sharing that story of your personal experience. It's always so important to anchor everything that we're doing in what really matters, so thank you. In terms of learning objectives today, well, I'm going to discuss a bit about informatics and AI approaches to enable learning health systems, and what we're all sort of trying to accomplish and have been for some time since the Institute of Medicine started to write about this, to describe the emerging examples of AI uses in kidney cancer clinical management. I'm going to touch on that just a bit, and also explain the importance of some other aspects that we're thinking about in terms of what we need to be doing as we are increasingly developing and deploying these AI solutions in terms of monitoring and making sure that they work appropriately. I think it's very appropriate that we kicked off here with a patient story. It's always helpful to anchor all of these things to a case, and so I thought I would come along and actually start with a case, and the case I'm going to start with actually is mine. It's not a kidney cancer case, but it's close, and I'm sure a lot of you will get it pretty quickly. So I'm coming up on my 6th anniversary of surgery for my tumor. This was me on December 11th, 2017, about to go into the OR, not feeling anywhere as good as my picture would suggest, and a bit anxious, and yet looking forward to having the operation I was about to have, because 2 months earlier, I started to experience severe acute paroxysms that took me to the emergency room with severe headache, profuse sweating, pallor, palpitations, panic, anxiety, flank pain, nausea, tachycardia, and severe hypertension. I was actually in Boston. I was going to be serving on a panel the next morning, and as soon as I laid down in bed in my hotel, I had the sudden onset of the worst headache of my life, and I went to the local emergency room there in Boston, thankfully one of the best hospitals in the world, and walked in and said, I'm having the worst headache of my life. So as you might imagine, I got whisked back, and they started to work me up. I actually had years of symptoms leading up to this that I had explained away. I'm just a sweaty guy. I have the occasional tremor, and I'm a little stressed out, but who isn't, that kind of thing. And I had headaches, but I just thought they were migraines. After an 8-hour workup, and they ruled out a bleed in my head, of course, they said, well, you've got atypical migraine and hypertension, you should go see a neurologist. And I went back home to Indianapolis, still feeling pretty terrible, had multiple other spells, went to go see a neurologist, and this begins a little bit of a theme. Because of who I am, I was able to get in to see a neurologist quite quickly, and I was diagnosed with occipital neuralgia instead of migraine because of the nature of the headache, and they gave me some injections in the back of my head. Should have helped right away, didn't. Went back to the institute I was leading at the time, and had another episode. This was my 6th, and while I was telling my assistant not to call 911 because it looked like I was dying, because I may have been, I racked my brain and just thought, what could this be? And it hit me, what this probably was. And I called my neurologist and said, I know this is going to sound crazy, but I think I have a pheochromocytoma. And she said, well, stranger things have happened. Let's check your blood work. And this is me after coming back. The results returned, and my metanephrine levels were 30 times normal. And that was my spot metanephrine check when I was feeling quite good, and my blood pressure was only 145 at the time. When I presented to the emergency room, it was 220 systolic, and I was, terribly symptomatic. But there was no question I had a pheochromocytoma. I actually got the labs back when I was on a trip a few days later, and had to come back home, and at that point called my primary doctor and said, hey, have you seen the results? He said, yeah, this is crazy, you have a pheochromocytoma. I said, I know. We need to get things moving here. So I need to see an endocrinologist. I need to get on an alpha blocker. I need to have a CAT scan, make sure this is solitary, as most of them thankfully are, and the like. And his initial response, understandably, was, I don't do this. Let's get you to an endocrinologist and sort of go from there. And I said, no, I understand, but the next episode could be fatal, and I need to get on an alpha blocker. So when I land, I'm going to go get an alpha blocker. It'll have your name on it or mine, but I'm going to start taking that. And it had his name on it, but still, I was able to accelerate that. I was able to accelerate seeing an endocrinologist. I was able to accelerate getting a CAT scan and my workup. And I had to push for all those things, but I was able to do it. But the thing is, I'm not bragging. I was able to do it because of who I am and because of who all of we are. We sort of know that we can, move through the system more quickly than a lot of people can, and that's not right, and that's not necessary. There are things we can do to actually help everybody get the kind of care that we otherwise can get. And sorry if you've, I think this is before lunch, so this should be okay. I finally then also was able to identify a great surgeon. Because of course there's only about 1,000 of these cases in the U.S. per year, and you want to go to somebody who's quite experienced at this. And turns out at the time there wasn't really anyone in Indiana, but there was somebody nearby in Ohio, and I still had my home there because of a recent move. So I went back there and had my surgery, and this is my 10-centimeter tumor that was delivered laparoscopically, and it was an amazingly successful procedure. And I was very grateful. And when I woke up from surgery, I had a few feelings. One, I was very grateful and felt very fortunate because, as you may know, 50% of people with pheochromocytoma succumb to pheochromocytoma. So not a malignant tumor in 90% of cases, thankfully, and I'm very grateful for that. And my genetics are negative, which is the case in 60% of cases, so I'm likely a sporadic case, and that means not a higher risk for my kids, which is good, and a lower risk of recurrence for me. But I still could have died, and I didn't, and it's quite possible, if not probable, that that's because of who I am, and the kind of access that I had, and the kinds of, and ultimately the excellent medical care I got. But leading up to that, I really had to drive a lot of that, and it's quite possible that wouldn't have been the case for someone else. And that's not right, and that's not necessary. There are many ways in which my diagnosis, my care, and the future care of others could be improved through informatics methods. And as an informatician, once I recovered from this, that really started me kind of thinking even more about this sort of thing, and only further motivates my work today. We must learn, and we must do better. So. Several lessons from this that I'll use then as I walk through the rest of my presentation to you. Lesson number one, diagnostic errors abound. You all know this in what you do. It's challenging to make diagnoses in any field, but certainly when it's a rare disease. And what we get taught in medical school is that when you hear hoofbeats, you think horses, not zebras, and that's a very reasonable way to teach medical students that common things are common, and if you see somebody with a headache and hypertension, it's probably a migraine and hypertension, and not a pheochromocytoma, which after all is quite rare. However, rare diseases do exist, and while rare diseases are rare, individuals with rare diseases are not all that rare. And so, we do need to be thinking about these things, and increasingly, as we learn more about the genetic basis of disease and the differentiation of subtypes and the like, we're increasingly going to be seeing more and more sort of rare variants and the like, and we need to be thinking about this a bit differently. And so I would advocate, first of all, that when you hear hoofbeats, you should think horses. You shouldn't just think horses, not zebras. You should expect horses, but consider zebras, at least. And in the informatics domain, this is something we've identified for quite some time. And in fact, there have been many attempts and ongoing work to actually develop systems for diagnostic decision support. And so some of those in the middle there, going back to the 80s, there's been work to develop expert systems that can help us by taking information and knowledge and creating initially rule-based systems and now increasingly artificial intelligence-based systems that can help us factor all the different data and available information and be able to recommend and propose diagnostic opportunities. And in fact, if a tool like that, one of those on the list was actually developed at the very university where I was in the emergency room, but it has not been incorporated into practice. It's not actually part of the electronic medical record implementation. Had it been, with a click of a button, the clinicians who were taking care of me, once they ruled out the bleed in my head, which is the more common and devastating concern, would have said, I wonder what else this could be, and it would help to develop a differential. And if you put my top 3 signs or symptoms into Google at the time, it's the top hit. I checked it again yesterday. It's not the top hit, but it's on the first page. And this is not AI. It's quite intelligent, obviously. There's a lot of technology behind Google. But the bottom line is, and I'm not advocating we go out and start using Google to make diagnoses, by the way. But at the same time, I mean, I think it just sort of illustrates that, you know, more information that surrounds us and technology that we have can really help, and we should be taking more advantage of it. Lesson number 2. While we want a learning healthcare system, one that actually improves from all of our experiences, we don't really have one today. And that's not a great revelation. But actually, it turns out we do have one type of way that we do learn systematically. And it's not a great way. And that's malpractice cases or, you know, severe errors that occur. And while we want to learn from errors, I think we can all agree this is not a good way to learn. You know, had something devastating happen to me after I left the emergency room, it's almost certain that that would have been considered, at least considered for a possible malpractice case, or because it was in fact a missed diagnosis with a rather classic presentation of a rare disease. And while it would have been heroic for the emergency room physicians to make one of the rarer diagnoses in their emergency room, at the very least, the mistake was discharging me while I still had all of the same signs and symptoms I walked in with, rather than admitting me. That is not, by the way, sort of a criticism. I understand the challenges that everyone's under. And again, because of who I am, I had the opportunity to call back and actually talk to those folks and, you know, let them know what they had missed. But I think it sort of demonstrates that we really need to be building a learning health system that actually can benefit from the errors that we make and the ways in which we can learn and be better equipped to take care of people in the future. And so the Institute of Medicine, now the National Academy of Medicine, has been writing about this for quite some time, as have many others. And there are many definitions of learning health systems, but one that I like, it's rather simple, is a learning health system is, those are healthcare systems in which knowledge generation processes are embedded into daily practice to produce continual improvements in care. There's a lot to unpack in every one of those words. Back in 2010, when we as a country started to invest in the deployment of electronic health records and really incentivize their adoption, there was, of course, the initial intent of that, which was to get these deployed and get them used so everybody had EHRs for, you know, the purported benefits that would come from those. And while I think we can all agree that that experiment has had its benefits and its failures, and there's a lot of work to be done to make the use of electronic health records better and reduce burden and do a lot of things that actually optimize the use of these technologies to the degree that we haven't fully realized yet. One of the things that was thought about up front and written about by the chief scientific officer at the Office of the National Coordinator at the time in this publication was that once we have this network of interconnected electronic health record platforms, we should not only be able to use it to take better care of individuals, but we should be able to use it to also advance biomedical research, public health, and healthcare quality improvement. And there's a whole subdiscipline of my field in clinical and translational research informatics that has been working on this for quite some time. And the virtuous cycle that we often think about in terms of creating a learning health system can be sort of exemplified in this diagram from Flynn and colleagues in Michigan and the Department of Learning Health Sciences that Chuck Friedman, my colleague and friend, runs. It's really an elegant way of thinking about what we need to do. And you can start anywhere, of course, it's a cycle, but if we start at number one with the collection of data, we then want to assemble the data, analyze the data, interpret those results, all in the context of a problem of interest, and be able to then represent that knowledge and present that to the right person at the right time to make the right decisions. So, all of you as clinicians, with the kinds of data and technology we have, can be benefited by decision support capabilities that increasingly are going to be driven by some more sophisticated, not just rule-based systems, but artificial intelligence-driven predictive models and the like. And then apply that into practice to improve what you're doing today, but also continue to iteratively improve that by looking at those cycles and seeing, okay, how did that work? Did it actually improve care? And how can we continue to make it better? So that idea of a learning health system, in this case, around a problem of interest, can also be zoomed out. And those of us who work on, behind every single one of these steps are multiple methodologies and technologies and approaches that we think about. And I'll talk a little bit more about that. Now, when it comes to leveraging the data in our electronic health record platforms, we have to keep in mind that there are, in fact, many caveats that we have to consider. As all of you know, when we capture data for individual patient care, we do it as good as we need to for the purposes of patient care. But that's not always the level of rigor and accuracy that we typically expect for research, for instance. And so when we start to think about that intersection, and those of us who sort of work in this area think about a lot of these caveats and how we need to address them. Number one, EHRs contain many inaccurate or even incorrect data. It's good enough for care, but it's not always fully accurate for various reasons. It often doesn't tell a complete story of the patient. Many of the data have been transformed or coded for purposes other than research and learning, and so we have to take that into account. Data are often captured in clinical notes. It's been estimated that 90% of the information that is actually locked away in electronic health records is in narrative text, and so being able to extract that with increasingly sophisticated solutions like natural language processing capabilities is something that a lot of us are working on. And EHRs can present multiple sources of data, and provenance becomes an issue. Where did that come from? What did it mean? What's the context? Data granularity can also not match the needs of some of our research questions, and there are differences between what we need to do for research protocols and care that often plague our knowledge and use of this. So a lot to work through, but I would argue that part of the reason why we're challenged at doing a lot of the things that we're trying to accomplish goes back to the fundamental way we think about practice. And this is a diagram from 1998. I could have picked any number of versions of a stepwise approach to the practice of evidence-based medicine. I was around long enough ago to remember when this was sort of introduced as a concept, and there was some controversy about it. I think we all now understand that evidence-based medicine is a goal, and we still don't do this as well as we should. But the idea is we generate evidence from research, we synthesize the evidence, we develop policies, we apply those policies, and then we take into account patients' circumstances, the evidence, and patient wishes, and we make the best decision we can for that. That's the idealized approach to evidence-based medicine. There's nothing wrong with this. We should be doing more of it, and there are informatics approaches. That's a whole other talk on how to make this better. But the point I want to make here, and what I want to draw your attention to, is the unidirectional nature of the relationship between generation of evidence and application to practice, which subtly and perhaps imperceptibly impacts the way we deploy our electronic health records, but actually the way we pay for care, the way we've organized our systems. We think of research and care as being distinct from one another in a lot of very important ways that have a lot of implications. And so as a result of that, including in issues of data, research and learning is often an afterthought when we're deploying electronic health record platforms, when we're developing our templates for how it is we're going to collect the data, when we actually think about how we're going to pay, and also when we are actually developing our regulations and our laws. And so, we often find ourselves struggling because we are pitting one ethical imperative against another. For instance, the ethical imperative of protecting patients' privacy, which of course is paramount and we have to do, with the ethical imperative of advancing discovery and being able to develop the next treatment and or diagnostic maneuver that can, and by having these not reconciled, it often leads to wasted investment and delays. The healthcare system financing model also does not really provide for any kind of work to develop a learning system. It's about taking care of one patient at a time. Anything beyond that is an additional cost, and that's burdensome. And we often expect IT to sort of solve these problems, but it's challenging, and we certainly often don't invest. So rather than the unidirectional sort of flow of research affecting practice, my colleagues and I wrote a paper a few years ago on the concept of evidence-generating medicine, so that we could start to really unpack what that means and how it is we need to do that, and the different enabling factors and stakeholders that need to play. But the main points are that clinical care activities are not entirely distinct from research activities, and we should recognize that and call that out. In fact, we are investing a lot in wanting these things to happen, and we make it hard on ourselves. And so we have to consider evidence-generating medicine when we practice to advance both science and care. In fact, there are a lot of these activities ongoing if we look at, certainly at our academic medical centers, but even more broadly at the kinds of quality improvement initiatives we want to do, but also the research initiatives around the development of clinical and translational science awards and PCORI and Cancer Moonshots and All of Us program and a lot of these different things that we're investing in as a nation that we expect we're going to learn from these data, but we haven't really worked on. And that advancing evidence-generating medicine is part of the evidence cycle. And again, there are multiple enabling factors, and we need to innovate in order to make this happen. If we go back even to my case as an example, and again, here I'll point out, I'm not advocating that we reorganize the healthcare system to find one of the rarest diseases, but I think even the simplest form of learning, what did I miss, is often really, really challenging for even individuals, much less the system to do. And so the feedback loops that we need are really key. But one of the keys there is that we often think, well, technology is the issue. We need to develop more technology. And in some cases, that's true. And certainly technology is not easy, and innovation is needed there. But as I like to joke, computers do what they're told, and people tend not to. So it's often the case that the challenging parts here are really about our socio-organizational systems. And so we often refer to, as I'll mention in a moment, socio-technical considerations. Before I get to that, I'm just going to talk a little bit more about some other lessons. Lesson 3, other data are critical. So you might have heard the sort of proverbial metaphor of looking for your keys under the lamppost. The idea that when you lose your keys out in the dark, you go look where the light is shining, not necessarily where you dropped them. And that's not the best way to find your keys. But it's easier because that's where the light is. And this is what we've tended to do for many, many years in healthcare. But this is not a perfect diagram, and I'm sure we could quibble with the exact percentages. But the point here to this pie chart is to say that there are many, many, many different factors that contribute to and inform and influence one's health. And at any given time, the data that we have from the healthcare environment is variably representative of one's health. So I would argue from the moment that I went to that emergency room to the moment that I had my operation, those 2 months, my medical record was a really accurate representation of my health status. Before that and since, it really hasn't been. How much sleep am I getting? What am I eating? How much exercise am I getting? What am I being exposed to? How much crime is there in my neighborhood? All these kinds of things are really, really important. And of course, my genetics and other factors. So we have to think about that. When I was diagnosed with my pheochromocytoma, I went back, and at that point, the Apple Watch wasn't capable of doing what it does today, which is tell you if you're having resting tachycardia. At the time, it didn't alert on that, but I went back and interrogated my Apple Watch, which I had been wearing for a year. And sure enough, when I downloaded the data, there was not a day that went by that I didn't have multiple episodes of resting tachycardia over 120. Now, if I had taken that series of spreadsheets, printed them out, and taken them to my doctor, what do you think they would have said? I know what I would have said. That's interesting. You hang on to that. I'm not really sure what to do with it. But yeah, that probably means something. I'm not really sure what. Let's look into that further. How are you feeling, et cetera. That hesitation, and that is understandable, but what it also suggests is we've got to figure out how to do this. And so, in our field, we have people working on this. How do we take advantage of these data? I mean, rather than sort of saying, gosh, I'm not sure what that means, these are data that are helpful and flowing around us, and increasingly we have all kinds of vast amounts of potentially valuable data that could have impacts on our ability to take better care of our patients and to help people stay healthy and get them healthy when they get sick around smart cities. I mean, for goodness sake, we have smart refrigerators now. So there's all kinds of data. Right now, those are largely being used for, marketing purposes and, to fix elections or whatever. But they're not really being used to, thank you for laughing, but not really being used for improving care. And that's a shame, right? We should be taking advantage of these things. Let's try to use these data for good, not just for, other things. But that's something we need to work on. And in the field of informatics, we think of that in terms of yet another ohm. So, we love an ohm. There's a phenome, the genome, and now we have the exposome. And there are various methods and approaches that we need to think about with the different types of data that we are in the process of integrating. For instance, some of these data exist at the level of individuals, but many of them don't. They're more sort of aggregated or at the level of, census tracts or zip codes or what have you. There's a lot of different privacy concerns, levels of granularity vary, but we have ways of addressing this and increasingly developing the approaches to be able to integrate all these and then learn how we can actually take advantage of them, whether it's for, training predictive models and being able to better provide guidance, or whether it's providing care, are things that we think about. Going back to my other point, the fourth lesson is that creating a learning health system and doing the kinds of data-driven approaches to improvements in care that we're striving for is really a socio-technical challenge. And so just to drive that point home, again, there are multiple information technologies that are important, but also fiscal and administrative considerations, the alignment of incentives, the addressing cultural and behavioral concerns and individual and societal concerns are all relevant to being able to, solve these issues. And we recognize that we need to build out the evidence-generating medicine capabilities, looking at this at levels of policy, systems, and individuals. So let's pivot for a moment to one aspect of what we're talking about, which is artificial intelligence. And here, I'm going to go back to my colleague and friend Chuck Friedman, who years ago, almost as a joke on a cocktail napkin, said, well, in our discipline, what's the fundamental theorem of informatics? And the fundamental theorem of informatics is that a person plus a computer should be better than a person by themselves. It's pretty simple, easy to laugh at, but it's actually pretty elegant. Computers can do a lot of things to help us. We're not fully leveraging those, and we need to do that. They're very good at pattern recognition and various other capabilities. They don't get tired, and they keep sort of working. With AI, we should be able to do even better, and I was recently talking with Chuck about maybe we need to update this to say a person with an AI equipped computer should be better than a person with a dumb computer, which should be better, of course, than the person without that augmentation or that capability to help them make better decisions. But we also have to remember that, and we're seeing increasing evidence of this, that we're still very in the early days here, and because of what I'm about to show you, we have a lot of concerns around bias and some limitations in terms of what we need to do. So for those who don't think about this as much as me and my colleagues do, just very briefly, a little high-level tutorial. How do we develop these algorithms? How do we do AI? So first, we have to acquire data. We train these algorithms on data. Whether it's analytical or so-called traditional AI, the analytical and predictive AI that you might be more familiar with, or the ones that everybody's increasingly become familiar with in the last year since OpenAI released their ChatGPT capability, generative AI, which is different about generating novel content. But either way, they're trained on data, and those data come from diverse sources, and we leverage what we have. But I think it's very, very important here to remember that those data are derived from our systems, which are part of our society, which inherit the societal biases and the systemic racism and all the things that exist in our society. And so we have biased data. We know that. And in some cases, we know what the biases are, but in many cases, we don't. And those who are actually developing these systems also have their biases. And in some cases, they're conscious of that, and in other cases, they're not. Then we train these models, and we deploy them into practice, ultimately. And that's usually where we stop. But one of the important things that, if some of you tracked it earlier this week, or maybe it was last week actually, the President's executive order came out, and there's others that are coming that are calls for ensuring that as we continue to use AI, we do that safely and effectively. And one of the keys to that is monitoring what it is we do, because there are many, many studies that show that, that in fact, if we don't monitor, we can have harm. Now here I'm going to pivot briefly to talk a little bit about something more germane to your specific area, which is the sort of emerging applications of AI in kidney cancer. And so this is, I thought, a nice little diagram to sort of summarize some of the areas in which we are seeing emerging work. And this is actually quite analogous to what's happening in a lot of fields. We see a lot of advances happening, particularly in imaging informatics, and the processing of images and the ability for artificial intelligence capabilities to be able to analyze images and be trained on vast image banks that are correlated with definitive diagnoses, and then be able to predict when the next image is presented what likely is the diagnosis, or what might even be the prognosis, et cetera, whether it's CTs, MRIs, radiology, or whether it's pathology images and histology. We're seeing that. So, for instance, on the left side there, when you're thinking about characterizing the size stage, AI assistance, and by the way, the A in AI we all know is artificial, but increasingly we're starting to talk about augmented intelligence as sort of another way of sort of representing that really these are meant to help us. But that is an area in which we're starting to see promise. Again, with pathology images as well, even in treatment management, both sort of preoperative planning and AI-assisted preoperative planning around what we're going to do in the OR, and then post-operative treatment as well, and AI assistance to be able to, even based on images that are captured radiologically before and after care and the like, be able to even start to predict what could be happening with regard to recurrence and the like, and prognosis. All of these things are happening. So just to get a little bit more granular about that, there's emerging evidence that is still nascent, but I think moving. What you see on the right there, by the way, is sort of a representation of some images where the AI has highlighted the tumor. This might not be one that was missed, but nevertheless, it sort of shows what the AI can do in an unaided way. So distinguishing benign from malignant tumors on CT scans actually increasingly is showing excellent performance, actually. And so that's one that is making its way, starting to make its way into practice, although the diffusion of this is happening more in the haves rather than the have-nots, but we're starting to see it emerge and be deployed. Distinguishing between different subtypes is harder. And that is not something that we're seeing great performance in just yet, even in silico, as we say, in the computational systems, much less sort of translating that into practice. But it's being worked on, and I think, if history teaches us anything, these continue to improve. So I wanted to highlight the ones even that, currently aren't quite ready for prime time or performing well. Similarly, when we talk about MRI and the more complex sort of images, we're not doing quite as well there with AI approaches as we are in CT, although, again, work is ongoing. With histologic images, the ability to differentiate subtypes and to determine grade is also performing pretty well, actually. And so we're going to be seeing more of this. Now, a lot of our histology is not digitized at the moment, and we don't necessarily have these computational systems. The infrastructure, the processes don't necessarily exist, but all of this is moving in that direction. The correlations of genomics of cancers with radiology images and pathology data is also increasingly happening, so that we can even predict based on images what the sort of genomic characteristics might be. And if we start to combine these different data elements, we anticipate that we'll be even better able to diagnose and prognosticate. The applications of AI to these tasks are limited. So these are all sort of being done in the lab still. Moving that into practice is still something that we don't see a lot of. And then predicting clinical outcomes based on pathology and radiology, as I mentioned, is sort of promise for future applications. But again, I think going back to the larger question, in the area of kidney cancer, it's relevant as it is anywhere. We have to concern ourselves with what's happening in terms of equity and how this would be applied. Not to slow us down in terms of where we know it works, but to keep an eye on this so that we don't inadvertently harm certain subpopulations. And so the growth in algorithmically driven decision support is vast, but we are already seeing a vast and growing literature on the harms that can result if we don't deliberately look at these issues. And so there's some articles there on the right that speak to this, but what I and others have been working on for some time is this concept of needing to monitor algorithms for care. Why? Because there are biases in the data, as I mentioned, some known, some unknown. We have to be cautious about generalizability. Just because an algorithm works here at Vanderbilt University Medical Center doesn't mean that if I take it and deploy it at your health facility, it's going to work the same way. Different populations, different data, but also different workflows, and we need to watch those things. There can be unexpected results, and frankly, if technology deployments have taught us anything, it's that if we can expect anything, it's the unexpected, so we have to watch for those things. In fact, we have to do this to promote trust. Not only trust among our patients, to whom this is going to be applied, of course, but trust even among us as providers and among our health systems who are investing in these things and society in general. We need new systems and approaches to make this work, and it's really essential that we do this for safe, effective, efficient, and equitable care. So years ago, I was sitting on a panel, and somebody said, what concerns you the most about sort of AI deployments? And I said, it's this. And I made the analogy at the time to pharmacovigilance, the idea that, once we've developed a drug and we put it out on the market, we should be continuing to monitor that. And in fact, there are scientific approaches for the collection, detection, assessment, monitoring, and prevention of adverse effects with pharmaceutical products that now have various ways we do that. We don't do this perfectly, but it is absolutely part of our sort of armamentarium of what we need to be doing. And there are famous examples of where we pull drugs from the market or put black box warnings on because we're watching for these things. So I proposed the idea of algorithmovigilance, and we are actually working to operationalize this. And that's the idea that we should have, again, methods, activities, and approaches to evaluating, monitoring, and understanding and preventing the adverse effects of algorithms in care. And the idea here, going back to the learning health system model, is that, yes, we have to develop these algorithms, study them, validate them in disparate data sets, and then deploy them. But rather than stopping there, we have to have this virtuous cycle where we continue to monitor and improve. The way we're thinking about building this and are starting to build it at Vanderbilt University Medical Center is what we call VAMOS, our Vanderbilt Algorithm Vigilance Monitoring and Operations System. It's a novel socio-technical system to be able to enable governance and oversight of our algorithms. And it includes what will be a dashboard with boundaries, looking at various metrics for accuracy and precision of the algorithms, drift, because we expect that they change over time, either because of changes in data or actually their effects, responsiveness to these over time and how that might change, and what that means, and then fairness and equity considerations. Feedback loops are essential to this, to both learn about what's happening, but also be able to send messages back to those who are using these in the front lines and to those who need to modify them. And possible actions that could result if we start to see issues include investigating the cause, correcting and updating the model, notifying the teams, and in some cases pausing the algorithm when we think it's fallen off or causing harm. We also are working on developing a maturity model, and we actually just announced this yesterday, in the same way that we have capability and maturity models, for instance, to say how mature is a healthcare system with regard to its deployment of electronic health records, for instance, and we have levels of maturity. We're going to develop levels of maturity to be able to say, how ready is my practice or my health system to actually adopt and use AI? And we have a grant from the Gordon and Betty Moore Foundation to look at this, and we have preliminary categories where we're going to be developing ways of measuring different aspects that are going to be relevant to certain entities around governance and leadership, the quality of data and representativeness, technological infrastructure to be able to do this, skills and competencies necessary to traffic in AI, the acceptability of it in care. Importantly to what we're talking about here, there are different specialty level considerations when it comes to AI that need to be taken into account. Of course, issues of how we manage ethics and equity concerns, and then the algorithmovigilance capabilities of our systems. And finally, I would say that, when I'm talking to an informatics group, I always emphasize this, but I'll emphasize it in terms of some take-home points for all of you. Supporting AI-driven learning health systems to enable discovery and care is paramount, and we need to work on this aggressively. Automation to improve and prevent and diagnose is essential. We need to enable transparency in our data where appropriate for quality and outcomes, like I was able to find a great surgeon. A lot of people can't do that. Identifying and improving what we're seeing as issues in healthcare disparities and equity, accelerating discovery and translation into practice, empowering people to be able to do more, including all of us, but also importantly our patients and their families, and ultimately creating these virtuous cycles. And we have to do this with urgency because people are suffering and they're suffering needlessly. And as I said at the top, you shouldn't have to be a well-connected, educated physician to be able to get great care. this system isn't working for far too many people, and we have to work to fix it. This piece of art is from an artist, now an endocrinologist actually in New York, Mike Natter, who drew this when he was a medical student. He was an artist before he went to medical school, and he would draw things to help him remember what he was learning. And when I got the pheochromocytoma, I found this online and was honored to buy his first print of this pheochromocytoma Hulk, and it's hanging in my office. And I had all of those things, and I would occasionally become a green rage monster, and now I'm just a mild-mannered scientist again, so I'm happy about that. So with that, I will stop. Thank you very much for your attention. I look forward to whatever time we have for Q&A. Thank you.
Wonderful. Thank you, Dr. Emby. That was so much food for thought and really interesting thoughts for us to how do we take this back to our practices. I learned a lot of new words, algorithmic vigilance, including one of them. That's yeah. Right. I think we have time for 2 questions, so we'll go ahead here.
Okay, great. Yeah, really interesting. 2 questions. One is AI sort of borderless. So we're developing sort of all these boundaries, or you're working on that. How do you deal with China, Russia, and all the other countries that are doing this that are not very concerned about it? And second is, can you give a specific example of what you mean about sort of fairness and equity and an algorithm messing up there?
Yeah, let me do that in reverse, because the first question is a little harder. So I'll give you a concrete example that's become somewhat famous in our circles. So about 4 years ago now, Obermeyer and colleagues wrote a paper about an algorithm that was developed using data from Optum, the payer, where they had vast amounts of data to be able to produce a predictive algorithm to help determine the chronic disease burden among patients, so that then they could make decisions about how much sort of healthcare resources to allocate, essentially how much healthcare to pay for. And they thought, well, let's do this in a way that is, fair by saying, well, if we can measure disease burden, then, we should be able to say, this is a patient who's probably going to need more care, more access, what have you. And because they didn't really have the data on the outcomes, and commonly this is what we do, we find surrogate markers for that. In that case, the surrogate measure was healthcare utilization. So healthcare utilization became a marker for, well, if you're using more healthcare, you must be sicker. You must have a higher disease burden. It's a very reasonable assumption to make. However, there are disparities in healthcare access, and therefore disparities in healthcare utilization. And so baked into that was therefore the fact that the black population was not as well represented as the white population in that data set. And the result was an algorithm that actually predicted that black patients had a lower disease burden than they really had. And when it was deployed into practice, black patients got less care, and they were harmed. And this was going on for a while, and it wasn't being actively monitored. And Obermeyer came along and studied it, found it, to their credit, went back to Optum and said, this is a problem, and they worked to fix it and adjust it. But had he not studied it, serendipitously, it would have continued to cause harm. So that's a concrete example. I think your point about boundaries is very important. It's a long answer, and I'm happy to talk more afterward, but I think that at a surface level, we do have to, I think part of the reason why we need vigilance is a lot of these algorithms are black box, and so wherever they come from, and ultimately get deployed, sometimes we know how they work, but in many cases, increasingly with AI, we don't. We actually, even if we built them ourselves, we often don't know how they're working. And they're rather sophisticated. There are famous examples now of, for instance, AIs being trained on a whole corpus of retinal images and having information such as the sex of the cohort, and it can actually say with great accuracy whether the retina it's looking at came from a male or a female, and ophthalmologists are 50-50 at that. And we don't know how it does it. So whether these algorithms are being developed by trusted sources or whether they're being developed by potentially not so trusted sources, if they look like something we might want to adopt and the like, we still need to be monitoring them. So that would be one part of my answer. I think there's, we all want to be able to leverage all the knowledge and capabilities that are around us, and that includes those that are coming from other places, but I agree that we can't be naive about sort of understanding that there may be some, nefarious reasons for certain things that are out there in the world, and we have to be aware of that. But I'd be happy to talk more about that offline. Yeah.
Wonderful. One more.
Yes, hi. Very interesting talk. So I think that the medical record has become like a big source of burnout for a lot of doctors.
Yeah.
And I don't know if like the AI is going to make that better or worse. Like we have algorithms in Epic that tell us you order Bactrim. Oh, it has an interaction. You keep canceling that message because it's not clinically significant. And to some degree, people keep canceling things that when the important one shows up, you actually dismiss it.
Yeah.
And I was wondering how this AI is going to help us, because if it's going to generate more workload on the physician, then where is he going to lead us to?
That's an excellent question, and you couldn't be more right. So what you're referring to is alert fatigue and the negative impacts of that, and it's a big, big problem. And so, for instance, at Vanderbilt, we have a group led by Dr. Adam Wright, the Vanderbilt Clinical Informatics Center, that along with colleagues Ali McCoy and others, developed an approach called Clickbusters, where we actually went through and started to remove. You can analyze what's actually useful and what isn't. What are the ones that everybody's dismissing all the time, and get rid of them. A group in Hawaii wrote about this in the New England Journal of Medicine a couple of years ago, called, I think the title was "Getting Rid of Stupid Stuff." So first of all, just because we have technologies doesn't mean we should just deploy them and use them and just assume they're going to do good. And it's naive to think that, if you just throw more alerts in there, all of a sudden things are going to get better, because there's all kinds of other, again, social and psychological reasons why that doesn't happen. And I think the other sort of part of your question I would address is that we can't presume that AI is necessarily going to make things better, and we have a lot of experience that it hasn't. Having said that, I think there are ways in which we shouldn't throw the baby out with the bathwater. There are ways in which generative AI capabilities, for instance, should be able to help us with with a documentation burden. I'll be brief about this, but when we deployed electronic health records, the amount of time, we always spent time documenting. About 35% of our time is the estimate across the board, when we were on paper. Now, depending on the study you look at, it's 50 to 60% of our time documenting. It went the wrong way. We have computers. They should be helping us. Instead, we added to our burden. And there's lots of reasons for that, but we need to make that better. There's no question. And there are ways in which we can use AI to make that better. I think, sadly, because of the burden and because of the sort of resource-constrained world in which we live, there's a lot of motivation now, and I think alignment to do that. But we have to be deliberate about it. And I don't think we can presume and assume that just throwing AI into the mix is necessarily going to make it better. We've got to do that in a very deliberate way. We've got to study it and make sure it's actually having that impact. And if it isn't, we need to adjust as we go. And I think that's the key, is that we too often just deploy these things and then assume they're going to work rather than continuing to sort of monitor them and optimize them. And that's really what we need to spend more resources on.
Wonderful. One more round of applause for Dr. Emby.
Thank you.
Thank you so much.